So Sam, what's new in the perioperative space for upper GI this year?
Yeah, Lizzy, it's a great question. At ASCO, we saw ESOPEC. We sort of laid to bed the question about cross versus FLOT. Now, FLOT is the standard for esophageal, but there was an open question about what about cross or FLOT followed by cross versus FLOT. And so Top Gear, which was just presented yesterday, really kind of laid to bed the question about radiation. And so FLOT followed by cross or ECF followed by cross does not improve survival versus perioperative chemo alone. So I don't know what you think, but I think this is kind of put to bed the question about local therapy adding to survival in esophageal and gastric and G junction.
Yeah, this is an easy one, right? So
Yeah.
radiotherapy, very useful in some circumstances, useful for squamous cancers, but it's about local control.
Yes.
Adenocarcinoma is a systemic disease. So local control, when you've got good surgery, you don't need to add to that. So sad for my radiation oncology colleagues, but that's the end for adenocarcinoma.
Yeah, totally agree. We also saw kind of an interesting question about, it's not so easy to give 8 cycles of FLOT, 4 and 4 after. So there was this abstract that was presented about correlating path CR with people who got no adjuvant versus adjuvant or major path response or no path response. And you've done your Vestige trial. And it looked like, although there were some caveats with the data, it looked like people who had a complete response to FLOT maybe didn't benefit from adjuvant, but are you still going to give these people adjuvant FLOT even if you see a nice response after?
For sure. I mean, this was a nice presentation, but it was a retrospective data set. It's not a clinical trial. The trials that we have, like Vestige, show that, if in poor risk patients, you've got to give more FLOT and it benefits them. But even in PCR patients, we have a 20% relapse rate.
Yes.
So in 20% of those patients, even if you see a PCR, there's still cancer there. So for me, give the FLOT.
Yeah, I think, we just, as a community, all got to get better about giving it. There's little dose tweaks you can make. There's extra supportive care, but it matters. We want to cure patients, and so you got to find a way to help your patient and get through it.
Exactly. Best we have for now, still waiting Matterhorn.
Yes, perioperative FLOT. So Lizzy, frontline space continues to evolve. We're seeing HER2. Now we've got some extra data. Maybe what did you think about the KEYNOTE-811 update?
So KEYNOTE-811 last year, practice-changing trial, but didn't have a positive overall survival benefit from a statistical perspective. So even though we adopted this treatment for HER2 PD-L1 positive patients, now it's squeaked over the line in terms of positive statistics, and so it was presented as an oral. So we know that this is a good treatment, right? So you've got 60% response rate, you've got good 20-month overall survival. This is good for patients, but only for the double biomarker positive. So I'm going to go back to that message again. And the message is, you got a double biomarker test. So HER2 positive, PD-L1 positive. Do not give pembrolizumab to patients who are PD-L1 negative. I think that's the biggest asset, right?
I think the hazard ratio for the CPS less than 1 is getting a little better. It was like 1.1 or whatever for this, but
still negative.
Still negative. So I agree. I think the FDA and the EMA are right along these lines.
So what I saw actually too was the Destiny Gastric 03. So TDXD, very useful drug in second line, very potent ADC, moving into first line, large trial, multiple arms, combinations with 5FU, combinations with chemo, combinations with PD-1, good response rates. But again, adding PD-1 to the HER2 positive, PD-L1 negative was not helpful.
Yes.
So this is 2 different disease biologies moving forward. There was very encouraging response rates for TDXD, encouraging progression-free survival. It is moving into first-line studies. So I think that would be very interesting. What are your thoughts on dosing for TDXD?
Yeah, I'll be honest. In clinical practice, I'll often start at 6.4 in a healthy patient, but have a very low threshold to dose reduce to 5.4. I think 5.4 is a dose that makes perhaps the most sense to bring forward, and in the US, that's the pan-cancer, HER2 positive dosing, and it seems like the appropriate backbone to add upon combinations.
And when we have PD-1, we've got to be aware of ILD.
Yes.
So we'll need to manage that carefully in the studies and keep an eye out for it. I think that's the most important message. Speaking of ICI, did we see anything new this year?
Yes, it's always been a question about how do you tackle immunotherapy resistance, and we don't really know the best way, but we do know that TGF-beta expression is increased in a lot of post-IO samples, and it is a mediator of intrinsic PD-1 resistance. So there was an interesting phase 3 from China comparing chemotherapy versus chemotherapy plus SHR-1701, which is a PD-1 TGF-beta bispecific. And not surprisingly, in CPS 5 or higher patients, we saw a positive phase 3 trial. I don't know what you thought. The numbers in absolute terms were really kind of aligned with what we've seen for just the addition of PD-1 on top of chemo.
Yeah. So I think this is the challenge with bispecifics. So they're helping some populations, we don't know who they are. Really, they're two drugs. And the comparison was chemo alone,
Yeah.
right? So really what we need going forward is this whole story of contribution of components. So trials will become more, I think, modular, maybe more arms, but all good. We need to explore the biology.
Agree. It would have been great to see that in CPS less than 1
Yeah.
if there's a signal.
Yeah.
They had greater than 5, so they kind of picked people we thought it might work anyway.
Exactly.